non-invasive ventilation in the long-term care setting. This is pretty much related to sleep apnea. The patient should have symptoms of chronic hypoventilation and lack of sleep quality. Patient should meet one of the following measurable parameters. You have a PaCO2 of 45 or greater, nocturnal saturation less than 88% for 5 minutes, an MIP or NIF less than 60 centimeters of water, or an FVC less than 50% of predicted. In the case of sleep apnea, the NIV may not be the first line of therapy. For example, you may try other methods like weight loss and curbing alcohol use, things like that. Exclusion criteria for the long-term setting is an unsupported family, copious secretions by the patient, the uncooperative patient, and a risk of aspiration. You certainly don't want to have that patient vomit and throw up into that mask and inhale it. Anatomic abnormality that interferes with gas delivery. The patient interfaces. The most common types are the nasal mask, the full face mask, or the mouthpiece. Less common is the total face mask, which covers the whole face, the nasal pillows, and the helmet. On the left, this is figure 45-7 on page 1144. This is a hybrid mask that does not apply pressure to the bridge of the nose. The bridge of the nose is a place where you have pressure sores that occur. And once they form, they just get worse and worse. So if anything you can do to prevent that sore is a major benefit for the patient. On the right-hand side is figure 45-8. This is a total mask, and you see that it covers the whole face. Now, the problem with this one is it actually applies pressure to the eyes also, but there seems to be less claustrophobia with it also. Some examples of nasal pillows, number of different varieties of this option. Again, nothing across the bridge of the nose. In visiting with some of the people that utilize these nasal pillows, most everyone seems to prefer them over a mask. The nasal masks are triangular in shape and cover only the nose, made of hard clear plastic with a cushion below for contact with the face. And then a strap assembly holds the mask on the face. However, you have to be careful, don't over tighten it because it'll cause necrosis across the bridge of the nose. So here's some examples of nasal masks. You see the one on the left-hand side also covers the mouth. So it may be, just depending on the type of mask that you have, will you need to cover the mouth or just the nose. I believe the center one is just a nasal mask and head strap. Okay, these head straps are, occasionally they'll have just Velcro attachments, or like on the right-hand side here, right here, this allows you just to snap it in place and you don't have to adjust the Velcro every time. Proper sizing of the nasal masks is probably the most important part of this. The proper sizing reduces the incidence of pressure sores and tissue necrosis, reduces leaks, increases patient comfort, and improves likelihood of long-term patient tolerance. There are a number of different masks, and finding one that's comfortable is a challenge. The one that I have at home is much more comfortable than the ones I see in the hospital setting, so it may be that they want to bring their own mask from home if you see these people in the hospital. This is figure 45-5 on page 1143 in your text. Templates help clinicians select an appropriate sized mask. Full face masks should rest on the bridge of the nose, 1/3 of the way from the top of the bridge of the nose, and the indentation between the chin and the lower lip. Sometimes these templates, it may be an external device like what you see here, or it may be part of the packaging that the mask comes in. But it's very important that you get the right size mask. The full face mask, this is kind of a confusing name because this one doesn't cover the entire face like what the name implies. It just covers the mouth and nose. This is the interface of choice for patients with acute respiratory failure. More than 90% of this group should start with a full face mask. It's designed for either non-invasive ventilators or ICU ventilators. Non-invasive ventilators, it has an entrainment valve that prevents asphyxia if the ventilator fails. However, the ICU ventilator's entrainment valve is absent. The disadvantages compared to nasal mask, this increases the dead space and claustrophobia and the risk of aspiration because now it covers the mouth. In addition, it's harder to talk to and cough and spit things out. If you want to spit things out, then you have to disconnect the mask and then reconnect it after you're finished. So here's an example of full face mask of each type. Right here is the valve that it was talking about. You notice on one side has a valve and the other side does not. Now for the non-invasive ventilators themselves. Most are electrically powered. They're blower driven. In other words, you don't have to plug them into the wall to get pressure. Just plug them into the electrical outlet, and microprocessor controlled. These are designed to work with a small leak and compensate for that leak, and in fact most of them require that you have a leak. The advantage is the patient's ability to trigger and cycle properly in the face of a small to moderate leak. An internal oxygen blender is desirable but often absent, and even then it's hard to obtain anything greater than 50% FiO2. If you need extra oxygen but you don't have an oxygen blender, what you do is you go attach a piece of oxygen tubing to the mask or somewhere on the circuit and just bleed oxygen in from a flow meter. At home that would probably be from an E-cylinder, in the hospital just from a flow meter on the wall. Here are a few examples of non-invasive ventilators. The far left and the far right are probably more of a home type setting, where the center one is one that you're going to see or something similar in the hospital. You notice that the far left and far right don't have a lot of adjustments on them, even though there might be a bunch of buttons. One that you would use at home is not going to be easily adjustable because you don't want the patient tinkering with it. On these ventilators, you typically have three modes, where you have something similar to CPAP, something similar to pressure support, and something similar to pressure assist control. With pressure support and pressure assist control, the machine is patient or time triggered, pressure limited, and flow or time cycled. They generate lower rates, pressures, and flows than ICU ventilators. The reason they might be time cycled because of the leak that's required. So if the leak is pretty big, you don't want to just set that thing blowing in their face, and it'll cycle after a certain amount of time and allow the patient to exhale. This is figure 45-12 on page 1148 of your text. Here's a pressure scaler and a volume scaler. This figure indicates the changes in non-invasive ventilation settings. In other words, the IPAP and the EPAP. IPAP being inspiratory positive airway pressure, and EPAP being expiratory positive airway pressure, and corresponding effects on the tidal volume. Section A is a spontaneous breathing on CPAP of 5 centimeters of water. Section B is a patient-triggered breath with an addition of 5 centimeters of water of pressure support. So what this means is that you have 10 centimeters of IPAP and 5 centimeters of EPAP. Section C, pressure support was increased to 10 centimeters of water. So that means IPAP of 15 and EPAP of 5 centimeters of water. A higher tidal volume occurs as pressure support is increased in A, B, IPAP of 15 and EPAP of 10. Section D, IPAP of 15 and EPAP of 10. Increasing EPAP settings results in a lower tidal volume because pressure support was decreased to 5 centimeters. Some of your critical care ventilators also have a BiPAP option on them. In other words, this is the Draeger, the Hamilton, the ventilators that you're going to run across an ICU that will do more complicated type ventilation. These ventilators are much more sophisticated and they allow for precise oxygen control, higher flows and pressures, etc. The inability to compensate for a leak is common though, and they often result in triggering and cycling issues. Pressure support breaths end at a set percent peak flow. If the flow does not fall to the set percentage, it may lock in inspiration. In other words, it fails to time cycle here. In some of the modern vents, you can adjust the cycle off percentage. Time cycling solves the problem and improves patient comfort. They often cause lots of nuisance alarms, and use of a full face mask to minimize leaks is sometimes a better option. Now, one thing about these total masks, not necessarily the full face mask, but the total, the one that covers the entire face, they are not disposable. So don't throw those away. Those are to be cleaned and reused. They're very expensive. CPAP, pressure support, and pressure assist control all have been used in the critical care ventilators. Volume controls are used but not recommended because the leaks lead to hypoventilation. Various NIV packages now available on ICU ventilators. Some will compensate for the leaks, allow for audio alarm deactivation, and set maximum inspiratory time, which again helps out if you have a leak. No proven advantages for any mode. These are but a couple of examples for critical care ventilators that offer a BiPAP option. On the left you have a Puritan Bennett 760, and of course on the right a Puritan Bennett 840, much like what we have in the lab. Even though you haven't placed an airway, you still need to be concerned about the humidification. Patients with symptoms of sneezing, nasal drainage, nasal or oral dryness, and or nasal obstruction benefit from humidity therapy. This is especially true if you leave the mouth uncovered. It takes you a little while to learn to sleep with your mouth closed. If you've been snoring for a long time, your mouth is typically open, and it will take you some adjusting to. And when your mouth comes open, what happens is this flow just dries your mouth out. As you're breathing, you're not really getting any pressure, and the flow from the ventilator just goes in the nose and out the mouth. And it will really dry your mouth out. And in fact, it'll wake you up if you're asleep. It'll get so dry and uncomfortable. So adding some humidity, especially heated humidity, relieves many of these symptoms, thus improving patient compliance. Heat to about 30 degrees Celsius. Remember, you don't have to have it at 36 because you still got your nose in play there. So humidification is recommended for all patients receiving non-invasive. Identifying success and failure. Success is easy to identify, where you have everything's looking better, right? Improved ABGs, the PaCO2 decreases, the pH increases, the PaO2 increases, the saturation increases, You have decreased respiratory rate, an increased tidal volume, decreased accessory muscle use. And in failure, if 1 to 2 hours, the above are not noted, if all those things don't happen, you're just going to scrap the non-invasive and go ahead and intubate them. And you don't want to wait longer than 2 hours because the results can be disastrous. Adjusting the ventilator NIV, determined by the patient's presentation and ABGs. If you have a high CO2 level, the pressure and tidal volume here are related. If you increase the pressure, you increase the tidal volume. If you decrease the pressure, you decrease the tidal volume. So depending on what your PaCO2 is, that's what you're going to do to your pressure. So if you have a high CO2 level, you increase the pressure, or you can increase the rate. If you have a low PaCO2, you decrease the pressure or decrease the rate. Many times in this setting, the rate is for backup only. If set in assist control, you may have the above effects, but patient inspiratory efforts override the ventilator settings. To adjust oxygenation, if you have a high PO2 level, decrease the oxygen or decrease the PEEP. Okay, and the PEEP here is the EPAP, end expiratory pressure. If you have a low PaO2, increase the oxygen or the PEEP. And again, if you increase the PEEP and you don't increase the IPAP, then it's going to compromise your tidal volume because now your ventilation pressure is going to be less. So as you monitor the patient using NIV, you have to be concerned about leaks. Leaks is probably the biggest problem here. And as long as they're laying on their back and they're not very active, it's probably not going to be an issue once you create a seal with the mask. However, the simple act of turning over onto their side could dislodge that mask and create a leak. So we always have to be careful about that. Accessory muscle use and ventilator synchrony and patient comfort is a big deal here. We need to make sure that when the patient makes an effort, the ventilator responds and is not auto-cycling. And so we're also looking for improved vital signs and blood gases. So if the patient worsens on optimal settings, think we probably need to intubate that patient. If the patient worsens on optimal settings, you probably need to go ahead and intubate them. Particular attention must be paid to those with respiratory failure. Adverse effects and complications. Causes of non-invasive failure include mask-related problems. This may be that we can't get the mask size appropriately, or the patient is too claustrophobic to have anything on their face. So there's a number of things there. Flow-related problems from the machine itself. Large air leaks if we can't get the masks sealed. Patient ventilator asynchrony, again related to leaks probably, and lack of improvement in gas exchange. See table 45-2 on page 1154 for a complete list there. Major complications, aspiration, hypotension, and pneumothorax. Of course, it's positive pressure ventilation, whether it's invasive or non-invasive ventilation. So you have to be concerned about the hypotension. This is table 45-2 from your textbook about the side effects and complications. At the top of the list here, the interface related side effects, discomfort here. Putting this mask on the patient sometimes is very difficult, and getting it to the right tension. You don't have to cinch this thing down because of the way the masks are built. Many times when you power the ventilator up and the first time it applies the pressure, it will create a seal because of the way the mask is built. As you strap this thing on the patient, make sure you just have the patient hold light pressure on the mask while you apply the straps. And many times that works just fine. You may have to readjust them, but don't start out with them too tight is the key. Okay, other problems, erythemia, claustrophobia is a big one, pressure ulcer across the bridge of the nose. Okay, um, and again, sometimes if you put a pad under the bridge of the nose, even if it causes a slight leak, it might work okay. You might be able to get something like that. I've seen people use, 2x2 dressings, even a couple of alcohol swabs that have dried to lay across there, just to get to where the plastic part of the mask is not touching the nose, and it gives them a little extra padding there. Air pressure related or flow related side effects. The nasal congestion. Now this is something that I'm not aware of. If anything, the pressure relieves the nasal congestion because I don't wake up with that at all when I use it. Where if I go camping or something and I don't take my CPAP machine, I'll wake up sometimes with nasal congestion, that edema that you get first thing in the morning, but I don't get that using my CPAP. The nasal dryness I will if I breathe through my mouth. Sinus or ear pain, eye irritation, gastric distension. Some of the serious complications, aspiration, especially if you have that mask covering the mouth. Pneumothorax is rare. Hypotension is rare, but you have to be on guard for it. Here's a good rule of thumb. This is actually on page 1151. Most patients in acute respiratory failure can be stabilized with an expiratory pressure of 5 to 8 centimeters of water and ventilating pressure of 8 to 12 centimeters. Avoid using peak pressures greater than 20 centimeters of water. So you can go up to 20 pretty easily without any problems. And I have seen pressures greater than 20, but that's the exception, not the rule.